So now that I told you all these horrible things about pulmonary hypertension, how do we actually treat it? And you know, this is a very complicated guideline, but it's available for reference. And I think what I wanted to focus on here is you know, the importance of getting somebody to an expert referral center if you suspect this disease, okay? So this is a patient that you can't really treat on your own if you identify it. They need to go somewhere that sort of specializes or has the expertise in this disease in order to treat it appropriately. But certainly, you know, if you meet them and they're quite sick or they need to be hospitalized, you can think about treating their right heart failure acutely with the usual, you know, diuretics. You can give them oxygen if they're hypoxic. You can tell them to avoid certain states that could put them at risk for, you know, life-ending complications. So we know that patients who sort of participate in strenuous physical activity, so, you know, obviously running or running upstairs or carrying heavy things, anything that makes them vagal, you know, kind of bear down and vagal, for example, if they're trying to really lift something heavy, you know, that can cause an acute right heart strain and can make them pass out and potentially lead to, you know, cardiac arrest. So we tend to say avoid strenuous activity. Pregnancy, the state of pregnancy alone, believe it or not, because of all the hemodynamic changes, unfortunately, we have to advise against. And in patients, especially young, obviously women, it's a terrible thing to have to tell them that they can't get pregnant with this disease, but it's for their own good. So things like that, you know, preventative things, as well as potentially treating their right heart failure. But eventually they get to a referral center, and you can think about, you know, proceeding with the next diagnostic step with this, which is the right heart catheterization. And I will say it's important to do the right heart catheterization in a center that specializes in this, because they know to do you know, specific testing in order to determine what treatment plan they go on to. So for example, there is a test that we look for whether or not these patients have somewhat reversible vasoreactive disease. And if they meet those criteria, they go on to this pathway, which is calcium channel blockers alone. And even though this affects a very small number of our patients, we don't want to miss it, because if we identify them, their prognosis is about 95% survival at 5 years, okay? And so we have to test for that on every patient with pulmonary arterial hypertension to make sure we don't miss it. Unfortunately, about 90% of patients tend to fall into the non-vasoreactive group, and these are the medications that we use to treat them, okay? When I started, there was probably only about 4 or 5 of these agents available, and now they've sort of exploded over the last 10 or 15 years. But this is taking us back to the mechanistic pathway of, you know, vasoconstriction and proliferation is something that we're trying to combat. So all of these agents using these 3 different pathways end with the vasodilatory and anti-proliferative effects, right? So we want to open up those blood vessels, and we want to sort of slow down, or maybe in the future reverse the development of these lesions that I showed you, these plexiform lesions, okay? And so there's the prostacyclin pathway, which is a natural pulmonary vasodilator that we try to enhance. The nitric oxide pathway is also a natural pulmonary vasodilator we try to enhance. And then the endothelin pathway is a natural vasoconstrictor that we try to inhibit with these medications, okay? So these are kind of the 3 pathways, and these are the drugs that we use available now. And patients will eventually end up on triple therapy, you know, in one of these 3 classes. They'll be on three drugs, at least in one of these 3 classes, before we say that they're maximally medically optimized, okay? And if they end up failing, which they unfortunately all typically end up failing at some point, triple therapy, that's where we kind of say we refer for lung transplantation. Bilateral lung transplantation is an option. Or unfortunately, if they don't want that, they proceed to death, okay? I will say one of the diseases that we can surgically treat is the group 4, or the clot disease, okay? So this is also something we don't want to miss. And this is a disease where clots, either from embolic places, you know, if they have chronic thromboembolic disease, or we think more that these clots develop slowly over time. It's not necessarily recurrent embolic PEs that are forming. This develops slowly over time in situ in the pulmonary vasculature and leads to blockages that way, okay? But this is where the VQ scan sort of shows us. This is a normal VQ scan. This is perfusion in the lung, looks very good and healthy lung tissue normal. This sort of area here is obviously the heart on the left side, so that's normal to be blocked out. But this is where we have a lot of blood clots in the lung. We have areas of the lung that are completely unperfused or underperfused because of these large clots sitting in the pulmonary vasculature. And you can imagine medical therapy may not do much for these clots, right? And so we send these patients to the University of California, San Diego, where they have a very rich program in surgical history of treating this disease. And they actually go in, and under bypass and all these fancy things that they do there, they actually remove these clots from the pulmonary vasculature. You can see this is almost like a cast of the pulmonary vasculature where they go in and in open heart surgery, they remove these lesions. And patients can be cured. So this is the one exception to the rule, that if we find this, we refer them to San Diego and we say, can you help this patient? You can imagine not everybody's a surgical candidate. You can imagine some patients don't want the surgery. You can imagine that some of the disease can be very distal and very hard for the doctors to reach, the surgeons to reach. So sometimes not everybody's a candidate, but they take a lot of cases. They do probably 1 or 2 of these, 8-hour cases a day. And we've definitely sent 20, maybe I'd say 10 or 15% of our population that we see here is CTEPH, and we'll send them there and our patients can come back cured, okay?